My name is Dan Hilleman. I'm a professor of pharmacy practice at Creighton University, School of Pharmacy and Health Professions. Today we're going to be talking about management of cardiac arrhythmias. And there are going to be three separate presentations for this topic. The first is going to be an overview of antiarrhythmic drugs. What are the basic therapeutic properties of antiarrhythmic drugs? And then the second two presentations will focus on management. The first, management of supraventricular tachycardias, and then the third and final presentation will be on management of life-threatening ventricular arrhythmias, primarily VT, VF, torsade de pointe. We will be using PowerPoint slides, obviously, with this presentation. And for those of you who choose to simply follow with audio, I will be doing my best to keep you kind of in place by referring to slide numbers. So the first lecture on antiarrhythmic drugs, the first slide is a title slide, so if we could move to slide 2. What you see on slide 2 is a summary of the Vaughn-Williams classification scheme. This is a classification that's been used for over 3 decades and was originally based on electrophysiologic properties of the antiarrhythmic drugs in the laboratory setting. How did the antiarrhythmic drug affect, for instance, a myocyte in terms of action potential, in terms of ion channels, etc. So I think the Vaughn-Williams classification still holds some importance in terms of allowing us to discuss the antiarrhythmic drugs. We'll talk about some general properties of antiarrhythmic drugs based on classification using Vaughn-Williams. But the reality is that it's certainly not perfect. For instance, Amiodarone is a drug that actually has electrophysiologic action that falls into all 4 classes of antiarrhythmic activity. It's a sodium channel blocker, it's a beta blocker, it's a potassium channel blocker, and a calcium antagonist. So the other, I guess, limitation is that antiarrhythmic drugs such as adenosine, such as digoxin, were not in the original classification, and I put them into what I call class 5, even though that's not part of the original Vaughn-Williams classification scheme, primarily because of their mechanism, which is predominantly to affect the SA node and AV node. So I do think it important that you recognize which drug fits into which class. Also recognize that most people feel that the class 1 drugs, the sodium channel blockers, and the class 3 antiarrhythmic agents are really the traditional antiarrhythmic drugs, and that beta blockers and calcium antagonists and even adenosine and dig, although they have antiarrhythmic properties, certainly have indications for things other than arrhythmias, I guess with the exception of adenosine. But so when we talk about traditional or classic antiarrhythmic drugs, it's really the class 1 drugs, the class 3 agents that most people think of as being pure antiarrhythmic agents. On slide 3, this table essentially tells you which of the ion channels are affected by the antiarrhythmic drugs. And again, specifically what we're looking at here are class 1 and class 3 drugs. And also then what effect these drugs may have in terms of different receptors. So you can see that obviously a drug like Amiodarone is a drug that has a broad spectrum effect in terms of a variety of electrophysiologic activity, Even the class 1A drugs have some effects, other than just on the sodium channel. So this gives you, I think, a sense that, yes, there's the Vaughan-Williams classification, which tells us that drugs work by primary mechanisms, but in reality, most of these drugs have multiple effects on the cardiac action potential and on the movement of ions across cell membranes. Slide 4, I think this is, even though this is, this is an advanced critical care course, we're not going to spend a lot of time with basic ECG interpretation. I do think it important to make sure that you're very comfortable with the electrocardiogram in terms of being able to monitor the antiarrhythmic drugs. I mean, typically, you've got to be able to know your way around an ECG in terms of what is the PR interval, what's the QRS duration, what's the QT interval, what do those represent, and how do we measure those? Oftentimes all we have are a rhythm strip, and we don't have computer-generated interpretation like you have, for instance, with 12-lead ECGs. So in a real-world monitoring setting, you have a single-lead rhythm strip, and you're asked, okay, is this patient suffering from a long QT interval induced by a drug, whether that be an antiarrhythmic drug or something else? So I think just important to recognize that all electrocardiographic paper is standardized. The small red boxes in terms of duration represent 0.04 millisecond or 0.04 seconds or 40 milliseconds. And that if you put 5 of those boxes together, they're separated by the thicker red lines. 5 boxes consecutively represent 0.2 seconds or 200 milliseconds. So oftentimes it's easier to talk in terms of duration on electrocardiographic paper in terms of milliseconds. What's the usual PR interval? Well, the usual PR interval is about 120 milliseconds. Anything over 200 is considered abnormal. What's the normal QRS duration? Well, anything over 120 milliseconds is abnormal. QT interval, what's normal? Well, normal is typically 320, maybe 360. Anything over 440, 450 is considered abnormal. So I think for those that work with arrhythmias in patients who are being treated with antiarrhythmic drugs, we typically talk about duration in terms of milliseconds. One other thing to point out, and I think this is important, and that is if we look at the QT interval. The QT interval is not just a representation of ventricular repolarization, but it does include the duration of the QRS, which is ventricular depolarization. One of the things that we're going to find is that there are certain class 1 drugs, the 1C agents, propofenone, flecainide, that predominantly widen the QRS interval, but have very little effect on what would be called the JT interval. The J point is basically that point on the EKG where the QRS returns to the isoelectric point. So, we think that the drugs that truly cause torsade, which is polymorphic VT associated with QT interval prolongation, tend to affect the JT interval, ventricular repolarization, more than they affect ventricular depolarization, which is represented by QRS duration. So if you move to slide 5, and this is, I think, where the value of having the Vaughan-Williams classification becomes important. We are able to talk about what are the general electrocardiographic effects of class 1A drugs, 1B, 1C, And so on this particular table, you'll notice a couple of things that I think are important to recognize. One is that the class 1A and 1C drugs, as well as class 3, generally are broad spectrum drugs in terms of they will prolong conduction through the atria as well as the ventricle. So you will see PR interval prolongation as well as increases in QRS, QT interval with the 1A, 1C, and 3 drugs. The other thing that's notable is the class 1B drugs, which were lidocaine, maxillatine, I believe tokenide, was one of those drugs, but now is no longer available, has essentially no effect on any of your EKG intervals, with the exception that the 1B drugs may shorten the QT interval. In fact, we have used maxillatine in patients with congenital long QT syndrome. The class 2 and class 4 drugs, the class 5 drugs that I've labeled adenosine, digoxin, all are specific to the atria. We don't see much effect of beta blockers or calcium antagonists or adenosine or dig on anything other than atrial tissue. Now, having said that, beta blockers, in part because of their effect on rate, may actually shorten the QT interval as well. So again, I think it's important to have a good understanding of what each class of antiarrhythmic drug does in terms of its effect on surface electrocardiographic intervals, and this table, I think, helps you understand those effects. The next couple of slides, and I believe we are on slide 6, has the pharmacokinetic properties of the antiarrhythmic drugs. And again, I think with what's happened with this class of drug, certainly the number of antiarrhythmic drugs that are used today are smaller than years past. A number of drugs have been removed from the market. They're simply discontinued by the manufacturers because there is no real indication for them. Quinidine, for instance, I don't believe is currently available anywhere. Procainamide is available intravenously but not orally. Tokenide, I believe, is off the market. So I think the important thing here would be to focus on drugs that continue to receive some fairly frequent use. So I think it makes sense to understand, for instance, procainamide we still use this drug IV occasionally, and it's a drug that when it's given intravenously has a mixed metabolic fate. It is cleared both by N-acetyltransferase, so it's metabolized in the liver about 50%. The other 50% is cleared unchanged, and so it's important to recognize that. Procainamide also has an active metabolite, N-acetylprocainamide, which we think is probably as potent as the parent compound. And N-acetylprocainamide will accumulate in patients with renal dysfunction. So procainamide is a drug that we typically like to think of as being 50-50 renal hepatic. So both renal and hepatic function would be important when you're monitoring a patient that may be receiving procainamide. But keep in mind that for the most part, today it's going to be used as a relatively short-term drug, and long-term administration is not going to be something that we're going to have to deal with. Disopyramide or Norpace is still on the market. One of the things about Norpace that's important to recognize is that it is a drug cleared to some extent renally, more than half. And in the package insert, there are recommendations for reducing dose based on creatinine clearance. The other thing is we'll find about disopyramide is that it's a relatively potent negative inotropic drug. And so it's actually used probably more for indications where negative inotropes are used, hypertrophic obstructive cardiomyopathy, for instance, than it may be for cardiac arrhythmias. The 1B drugs, again, maxillatine I think is the oral drug that's still available. Lidocaine still available and is still part of the cardiac arrest guidelines. Lidocaine is one of those drugs that's purely cleared by the liver, a very high rate of hepatic clearance, metabolized to several metabolites, a couple of which are potentially therapeutic, but certainly neurotoxic. And one of the things that's interesting about lidocaine is that it has a relatively large volume of distribution. We generally like to give loading doses of lidocaine to fill that volume of distribution. Also, it's one of those drugs that essentially the only thing that limits its half-life is blood flow to the liver. So if you have a situation, for instance, such as heart failure or liver disease, which can affect hepatic function, or that can affect blood flow to the liver, that will increase your half-life of lidocaine. So the half-life of lidocaine is directly related to the effect of blood flow to the liver and disease states that can adversely affect metabolic capability of the liver. Mexilatine, 80% cleared, 2D6 metabolism, so there is the theoretical potential for patients to be slow metabolizers. Also the theoretical potential for drug interactions at 2D6, but it does not appear that it has active metabolites. You'll notice on the slide, that extensive metabolizers have a half-life of about 9 hours, so the drug could be given Q8 in those patients. Poor metabolizers have a half-life of 18 hours, so they may get by with twice a day or even once a day dosing, and it's tough to know, where patients fit in terms of being extensive or poor metabolizers prior to initiation of drug therapy. Slide 7 has the Class 1C antiarrhythmic drugs, their pharmacokinetics, and these are drugs that still are used to a fair amount, particularly for atrial fibrillation. We don't see them used a great deal for ventricular arrhythmias, although that was the original indication. Predominantly, they're being used for patients where you're trying to maintain sinus rhythm after patients have been cardioverted from AFib. I think the key here is both flecainide and propafenone are cleared by 2D6. And again, 2D6 is, there's genetic determinants of the extent to which the amount of 2D6 you have in your system, in your liver. And so there are poor metabolizers, extensive metabolizers. The nice thing about flecainide is that only about 60% of the drug is cleared by 2D6, by the hepatic route, 40% renally. So if you encounter a patient that is a poor metabolizer, then I think the nice thing is you're going to have the lesser potential for accumulation of flecainide and adverse outcome. Whereas with propafenone, what you have is 95% clearance by cytochrome P450, the 2D6 isozyme. So you have, if you notice the half-life for propafenone, you have extensive metabolizers that have relatively short half-lives, 4 to 8 hours. You have poor metabolizers that half-lives range from 11 up to 25 hours. So, even in that poor metabolizer group, the amount of enzyme that's available, this is not an all or none phenomenon. It's a continuum, and there are patients with very low quantities of 2D6, some with more moderate quantities, and then some with probably near normal quantities of 2D6. So the polymorphism that occurs in terms of genetic code that is responsible for manufacturing those isozymes, this is not an all or none phenomenon. It's a continuum of effect. And so even in poor metabolizers, you can see a wide variability in the half-life of propafenone. So patients who are truly poor metabolizers are more likely to have toxicity with propofol since such a high percentage of the drug is cleared by that particular isozyme. Slide 8, these are the kinetics for the class 3 antiarrhythmic drugs, and I think the important thing to recognize here is that we're really looking at a heterogeneous group of drugs. I mean, there's great variability among these agents. They can't easily be classified as we did, for instance, with the class 1C drugs. Amiodarone is probably the most unique. It has, one, relatively poor bioavailability, an average probably 50% bioavailability when it's given orally. Has a very large volume distribution, 66 liters per kilo on average. It has a half-life of 53 days. It has an active metabolite that has a half-life that's very similar, about 53 to 55 days, the des-ethyl amiodarone derivative. Its potency is thought to be essentially the same as amiodarone. And so if you decide that you're going to check levels, blood levels, of amiodarone, and there aren't very many settings where that's necessary, we recommend you look at both amiodarone and des-ethyl amiodarone. Amiodarone is totally metabolized, 100% metabolized by cytochrome P453A4 and 2C9. It also is an inhibitor of 3A4 and 2D6. So it has a number of potentially important drug interactions at the level of the liver. So its kinetics certainly make for an interesting drug in terms of the volume distribution, requiring a large loading dose, and in terms of the long half-life, which makes monitoring challenging in terms of when do you see the peak effect of this drug. With a half-life of 57 days, it may be difficult to say that, at 72 hours we've seen, a peak effect. There are a couple of drugs in the class 3 agents that are predominantly cleared renally. And both dofetilide and sotalol, there are treatment or dosing nomograms that were part of the original FDA-approved package inserts. Those still are valid, even though sotalol is now generic. And it is important that we follow those dosing nomograms. So dofetilide, renally cleared 80%, sotalol 80 to 90% renal. Those are drugs clearly where renal function is very important in terms of monitoring. We are going to spend some time talking about a new amiodarone-like derivative, a drug called dronedarone. The trade name is Multac. It's been approved in the United States for a few months, going back into 2009. And we will be talking about it at some length when, at the end of this particular presentation. But a couple of things that are interesting is that it also has very poor bioavailability. It should be taken with food to improve that bioavailability. It appears to have a large volume of distribution, but its half-life is relatively short, and it actually is administered twice a day. But it is extensively metabolized by cytochrome P453A4. It has an active metabolite, but the potency of that active metabolite is relatively low compared to the parent compound. And because of that shorter half-life, it's a much more manageable drug compared to amiodarone. Ibutylide, I don't know that the kinetics are all that important. It is predominantly cleared through the liver. And the reason that I don't think it's predominantly or essentially important to understand its kinetics is a drug that's used to convert AFib, but it's given only, if you will, as a direct IV injection. And it's only typically given as 2 IV direct injections, and that completes the course of therapy. So, its kinetics really don't play a major role in our decision to use or not to use or how to monitor ibutylide therapy. Slide 9, I had a difficult time finding what I thought were adequate resource in terms of what were the recommended doses for the currently available antiarrhythmic drugs. So I put together a table that you can see in slide 9 and also in slide 10, which gives you recommended IV loading doses, IV maintenance doses, oral loading, oral maintenance doses for the drugs that are still commonly used. So I haven't included drugs like toconide or quinidine or beryllium that no longer are used. But I'm not going to read through this. You can use this as a resource in your own practice. But I think it has what I consider to be the most appropriate recommended doses for the average patient that you would treat with antiarrhythmic therapy. Slide 11 and 12, we're going to talk a little bit about the cardiac toxicity of antiarrhythmic drugs. And I've tried to summarize these in terms of, one, do the drugs produce bradycardia? And there are some that have significant potential to cause bradycardia. What's their potential for causing conduction disturbances, heart block? Do they lower blood pressure? And if so, how do they lower blood pressure? Is it a reduction in heart rate, or is it a reduction in vascular resistance? What's their ability to worsen or precipitate heart failure? And then finally, what's the type of proarrhythmia that these drugs can cause, and how frequently does that occur? So if you look at slide 11, I've got these grouped by Vaughn Williams classification, and you'll notice that quinidine procainamide at the top, those are class 1A drugs. The potential for heart block is relatively minimal, I think. They do have effect in the atria, but not especially potent in terms of slowing conduction through the AV node. Quinidine and procainamide can lower blood pressure. Quinidine had some alpha blocking effect. Procainamide had some ganglionic blocking effect, and so particularly when those drugs were given parenterally, then there were concerns with hypotension. And even today, procainamide, typically we like to limit rates of administration to 20 milligrams a minute, 100 milligrams over 5 minutes, to minimize that potential for hypotension. Quinidine procainamide, I don't know, had tremendous negative inotropic effects. Certainly, you have to be cautious with most antiarrhythmic drugs in patients with heart failure, but I would say on average, quinidine procainamide, if someone had pre-existing heart failure, it could make heart failure worse, but they were not particularly potent in terms of their negative inotropic effect. Where they did have significant effect was in prolonging the QT interval, and quinidine in particular, well known as a drug that could cause torsade, DePoint, which was polymorphic VT associated with QT interval prolongation. The one difference among the 1A drugs that I think is worth mentioning, and I mentioned this earlier, is that disopyramide is a drug that's a very potent negative inotrope. And it's actually used in patients with outflow tract obstruction in the ventricle, patients that have a hypertrophic cardiomyopathy that limits blood flow out of the ventricle. Negative inotropic drugs sometimes are used to minimize the systolic force of contraction, and disopyramide has been used for that indication. The interesting thing about the class 1B drugs, lidocaine, mexiletine, toconide, is that they had really no important cardiac toxicity unless you gave very high doses. We've had a case report in the literature of a patient that received a toxic dose of lidocaine that developed a Mobitz type 2 heart block, required temporary pacing. But that was an extreme situation. For the most part, And I think one of the reasons lidocaine was so commonly used in people with acute infarction is that these drugs had little effect on any cardiac parameter. They didn't worsen heart failure, did not cause heart block, they did not cause bradycardia, they did not cause a proarrhythmic effect. And so were relatively safe even in those patients who were the sickest in terms of cardiac function. The 1C drugs, flecainide, propafenone, generally very little effect on heart rate. Propafenone has been suggested to have some beta blocking effect, and so it may slow heart rate somewhat more than flecainide. Both drugs have the potential to cause heart block because they are relatively potent in terms of their ability to block conduction through the AV node. One of the reasons that they're fairly effective for managing atrial fibrillation. Neither drug probably has much of an effect on blood pressure, primarily because, at least in the United States, they're only available orally. Both can worsen or precipitate heart failure. And I think this is an important point. You've got someone with significant problems in terms of heart failure, low ejection fraction, then you want to be very cautious if you're considering propafenone or flecainide. In fact, many consider heart failure to be a contraindication to using flecainide or propafenone. And the interesting thing about these drugs, I mentioned earlier when we talked about the electrocardiographic effect of these drugs, the proarrhythmia that occurs with flecainide and propafenone is a monomorphic VT. It's not typically associated with delayed or prolonged ventricular repolarization. So these drugs can widen the QRS complex. They affect ventricular depolarization, but generally don't have much effect on the JT interval. So from that perspective, what we saw early on with these drugs is that patients would develop a monomorphic VT that's difficult to distinguish from VT that just occurs as a result of organic heart disease. And doses of these drugs were being increased, thinking, well, this is VT, we need to suppress it. Let's give a higher dose. And the VT would get worse. In fact, it would get to the point where the VT was refractory to shock, electrical shock, and patients would end up dying from the proarrhythmia. So the recommendation for these drugs is not to make frequent dose increases. You have to be monitoring the patients for changes in QRS and QT interval, and probably not making dramatic increases in doses more often than every 3 to 4 days. Some of the other, if we look at slide, I think we're on slide 12. Some of the other drugs in terms of cardiac toxicity, and again, these are mostly the class 3 antiarrhythmic agents that you see on this particular slide. Amiodarone is really, I think, unique in that its cardiac toxicity is generally pretty manageable. We know that it causes some significant bradycardia. In fact, I think most patients who are on amiodarone tend to develop some slowing of sinus rate. It also has the potential to cause heart block. It can have an effect on the AV node that's important. Generally, the oral form of amiodarone doesn't have much effect on blood pressure, but the IV form of amiodarone can lower blood pressure, and we think that it may be related to a detergent, basically an emulsifying agent that's added to put amiodarone into solution. So the additive is called tween 80, and we think that it may be that additive in the IV formulation that's responsible for the hypotension that occurs with IV amiodarone. One of the things about amiodarone that is, I think, particularly important is that it has been studied very extensively in patients post-MI, patients with heart failure, and so it does not worsen heart failure to a great extent. Even though it does have the ability to widen the QT interval rather dramatically, the incidence, the prevalence of torsade with amiodarone is really quite rare. So you can see patients whose QT intervals widen out to 500 plus milliseconds, and it's uncommon for these patients to develop torsade, which is we don't know exactly the reason, but we know clinically it's unusual for amiodarone to cause torsade. And I think the reality is that the torsade that we've seen with amiodarone generally occurs when another drug is combined with amiodarone that also produces QT interval prolongation. Dronedarone, again, we'll spend more time with this drug in a few minutes, but interestingly enough, unlike amiodarone, it does not appear to have much effect on heart rate. It doesn't cause much in the way of bradycardia. We think it has the potential to cause heart block. It is indicated primarily for atrial fibrillation, so we think the potential to cause second-degree heart block is there. So we don't think that it causes it at a great extent, but certainly the potential for it to occur. Probably doesn't have much effect on blood pressure, a very modest effect, if any. The one difference about dronedarone compared to amiodarone, beyond the bradycardia issue, is that it's relatively contraindicated in heart failure. Patients with class 4 heart failure, it's contraindicated. Patients with class 2, 3 heart failure who've had a recent decompensation or have been referred to a heart failure clinic, it's contraindicated. And we don't know that it's necessarily a drug that worsens heart function, but we'll talk about this later. It was studied in a trial where patients with heart failure had an increase in mortality with dronedarone, the exact opposite of what happened with amiodarone. So for right now, very cautious use of this drug in patients with low ejection fraction or a history of heart failure. We also know that dronedarone, though, also is not likely to be proarrhythmic. Very low rates of proarrhythmia in the trials that have been published to date. So it does not appear that dronedarone, even though it does widen the QT interval, unlikely that it's going to cause torsade. Dofetilide is, again, indicated only for atrial fibrillation. So it may have some effect on heart rate. It may have some effect on causing heart block. Probably very little effect on blood pressure. Along with amiodarone, dofetilide has been studied both post-MI and in patients with heart failure, and we know that it can be used safely in both of those populations. So generally the recommendations, if you have a patient with significant heart failure, the two choices that are generally recommended for those patients are amiodarone or dofetilide. I think the major limitation with dofetilide is the potential for causing torsade. It widens the QT, and certainly torsade can occur with this drug. So there is obviously a dosing algorithm that has to be followed. And as the QT interval widens substantially at the start of therapy, then the recommendation is to discontinue dofetilide. Ibutylide, generally not much effect. Again, it's only indicated for conversion of recent onset AFib. So, in terms of bradycardia, heart block, heart failure, hypotension, those are generally not major issues. The big concern with ibutylide is torsade, and it appears that perhaps up to 10% of patients may develop torsade. So it is a drug that clearly, has to be used in a hospital setting. You need monitoring. And I think when we talk about managing AFib, you'll see that I think most institutions have tried to move away from using pharmacologic cardioversion for AFib because of that risk of torsade. Sotalol is a beta blocker which also happens to have class 3 antiarrhythmic activity. So it can cause bradycardia, it can cause heart block, it can cause hypotension, it can cause worsened heart failure. One of the problems with sotalol is that it has not been tested as a beta blocker for mortality reduction in the post-MI patient or the heart failure patient. And so we're always concerned, is there enough beta blocking activity with a drug like sotalol to assume that it reduces mortality like other beta blockers? And I don't think we have that data. And so I think that really limits its application because so many patients that we want to treat with sotalol also have heart failure. They also are post-MI. Do you add another beta blocker on top of the sotalol? And we see that happen. The other obvious disadvantage of sotalol is that it does cause torsade, widens the QT interval. It needs to be monitored again fairly carefully. The only data with sotalol in high-risk population was done with one of the isomers of sotalol, which was thought to have pure class 3 antiarrhythmic activity, and it was the D isomer of sotalol, and it actually increased mortality in the post-MI population. So again, we're very cautious when we look at sotalol. Patients with heart failure, patients with recent myocardial infarction, oftentimes we consider the sotalol being contraindicated in those settings. I'm not going to say a whole lot, slide 13, about the cardiac toxicity of beta blockers and calcium channel blockers. And when we're talking about calcium channel blockers, we are really referring to the non-dihydropyridine drugs, verapamil, diltiazem. These are the cardiac toxicity of these drugs directly related to their pharmacologic activity. They can slow heart rate, they can cause heart block, they cause hypotension, they can worsen heart failure if they're not used carefully, if you give too high of a dose or titrate dose too rapidly. The beauty of both classes of drugs, though, is that they do not have the potential to be proarrhythmic. But you have to be careful with particularly calcium channel blockers in patients, for instance, who may have what looks like SVT, but it turns out it's VT, because they have no effect on the ventricle. So they may drop blood pressure in a patient who has VT and make that situation even worse. So neither of these drugs have what I would call unexpected cardiac toxicity. These are things that are very consistent with their pharmacologic profile. Amiodarone, I think everyone is aware that it has a long list of non-cardiac toxicity, and we'll get to that in a minute. The other antiarrhythmic drugs, as you'll see on slide 14, most of the ones that I think had significant non-cardiac toxicity are no longer available. Quinidine, for instance, caused a lot of GI side effects. It was associated with a phenomenon called synchonism. Quinidine was originally derived from the bark of the cinchona tree and produced a hypersensitivity-like reaction. Hepatotoxicity, thrombocytopenia, procainamide long-term associated with lupus and neutropenia. We don't use procainamide long-term anymore. Toconide, pulmonary fibrosis, neutropenia were reported with this. Again, it's not available anymore. So the drugs that we use long-term, that if you look at this list, mexiletine, the class 1C drugs, flecainide, propafenone, Maritzancin, I don't believe, it's been discontinued for 2 or 3 years now. Dofetilide and sotalol, all of those drugs I just mentioned in terms of non-cardiac toxicity are pretty well tolerated. I mean, they have some side effects, mostly CNS and GI. But the non-cardiac toxicity are not the most concerning problems with those drugs. The most concerning problem with most of those drugs is their proarrhythmic potential, with the exception of mexiletine. Amiodarone on slide 15 There is a laundry list of toxicities, non-cardiac toxicities. Most of these are well known. GI, I think most of the GI effect, with amiodarone occurs during the time that you load therapy. And if you split the dose, give it 3 times a day with meals, then I think you can minimize some of that GI toxicity. Central nervous system side effects do occur. The ones that I think are the most common have to do with tremor and then ataxia. And if that's allowed to progress, there are reports of peripheral neuropathy. We're not exactly certain of the mechanism, but we think that because it is so lipophilic that amiodarone tends to accumulate in peripheral nerves and can actually cause peripheral nerve dysfunction. And so if you have a patient who develops tremor that progresses to paresthesia or to ataxia, I think that's the time that you're going to discontinue this drug. Sleep disturbances have been reported, so CNS side effects are not uncommon with amiodarone. Pulmonary toxicity with amiodarone, I think early on was the thing that really was of most concern. I recall early on in my practice, had patients that were receiving amiodarone at relatively high doses who had developed pulmonary fibrosis. A couple of patients ended up actually requiring intubation, had to be put on ventilators. They had such severe fibrosis. One of the things that's happened, I think, is that we understand today that low doses of amiodarone are much less likely to cause pulmonary toxicity. There is a pulmonary hypersensitivity phenomenon that can occur early in the first few weeks, relatively rare. The more common type is the pulmonary fibrosis that takes months to years to develop. But again, I think if we limit our doses to 400 milligrams per day or less, and certainly 200 milligrams per day or less, the risk of pulmonary toxicity is much lower than it was, in the past. A lot of potential dermatologic problems with amiodarone. It can cause skin rash, blue-gray skin discoloration, so photosensitivity. These are not uncommon with amiodarone, and certainly need to be considered if you start someone on amiodarone and they develop a rash. Best to have them see an expert, a dermatologist, to see what can be done to deal with that problem. Slide 16, hematopoietic side effects with amiodarone have been reported, but they're relatively rare. I don't think this is a common problem with amiodarone. Amiodarone can cause both hyper and hypothyroidism. It's kind of a funny thing that you have a drug that can produce such disparate effects on one organ. But I think the explanation, to make this somewhat simple, is that if iodine is 40% iodine by molecular weight. So if you give amiodarone to a patient, in essence, you're giving them some iodine. And that iodine in a normal patient tends to want to shut down the thyroid gland. It tends to suppress thyroid function. Well, the majority of patients, the thyroid escapes the effect of that exogenous iodine, and these patients continue to be euthyroid. However, somewhere around 8 to 10% of patients will become hypothyroid, and testing and clinical monitoring are important to detect hypothyroidism, but it's generally relatively easily managed just simply by giving L-thyroxine replacement therapy and monitoring thyroid function. Hyperthyroidism is probably a little bit more difficult to deal with, and there are 2 types. One is relatively rare, but there are some patients who develop an immune-mediated hyperthyroidism where amiodarone appears to induce antibodies to the thyroid gland. those antibodies produce an inflammatory reaction in the gland. Preformed thyroid hormone then is released and produces a clinical syndrome that is similar to thyrotoxicosis or thyroid storm. So it's an allergic or hypersensitivity type reaction. Initial management, obviously, is stop amiodarone, use corticosteroids to reduce or minimize the inflammation in the gland, and to protect the heart by giving beta blockers. Sometimes IV beta blockade is required, as Malal, to control, the adverse effect of excess thyroid on the heart. Generally, these patients should never be exposed to amiodarone again, and if it's caught appropriately early enough, these people typically recover. The other type of hyperthyroidism occurs in patients that we believe have subclinical thyroid disease. They have non-toxic thyroid goiter. They have, at ultrasound, a large vascular thyroid gland. And when you give them iodine in the form of amiodarone, their gland overproduces thyroid hormone. So the management strategy is varied. Some have given some antithyroid drug like propylthiouracil. Others have done subtotal thyroidectomy surgeries. Others have given radioactive iodine. I think that the reality is that for patients that develop this kind of hyperthyroidism, if you can stop the amiodarone, find an alternate agent, that would be preferred. But it probably requires an endocrine specialist to manage these patients through the acute phase and get them stabilized, until the situation is resolved. Eye or ocular toxicity with amiodarone, it's said that every patient who receives amiodarone for any period of time will develop lipoid deposits in their cornea. The good news is that most of these lipoid deposits do not interfere with patients' vision. So you get relatively few complaints of visual disturbance with amiodarone. But the thing that is disturbing is that there have been some reports of optic neuritis and macular degeneration in patients receiving amiodarone. And whether there's a direct link or not, there is a boxed warning in the amiodarone package insert telling us about these effects, and that patients need to see an ophthalmologist or an optometrist, someone that can examine the inside of the eyeball, look at the optic nerve, etc., at least on an annual basis. So, this is serious, loss of vision, blindness, clearly is a very serious potential side effect. Again, it's very rare that it occurs, but I think for the safety of the patient, at least annually should have the complete eye exam. Liver toxicity with amiodarone, if there are elevations in serum transaminase, the ALT, AST, particularly if those are 2 to 3 times the upper limit of normal, amiodarone probably should be discontinued. We do know that there are patients that have gone on to develop fulminant hepatic failure with amiodarone, and so it should not be ignored. Patients need to be tested periodically for increases in serum transaminase levels, and if they increase substantially, stop the amiodarone. On this particular slide, which is number 17, this is actually the recommendation from the Heart Rhythm Society. It used to be the electrophysiology group. But it gives us in tabular form recommendations about long-term monitoring of amiodarone. It tells us what tests need to be done at baseline and then at 3 to 6 month intervals or annually. And so obviously, thyroid and hepatic function blood tests need to be done. I think initially at 3 months, and then you could probably go to 6 months, and then every 6 months thereafter. Some of the things, electrocardiograms, the complete blood count, the basic metabolic profile, should be done as part of routine health for most patients. The eye exam needs to be done at least annually. One thing that's important to recognize is that pulmonary function tests and chest x-rays, if you do those serially, they probably are not of any value in terms of identifying pulmonary toxicity earlier than simply looking at changes in pulmonary function from a clinical perspective. So I think one of the things that we tend to forget, and this is the most important part of monitoring amiodarone, is that patients on chronic amiodarone therapy should see a licensed healthcare provider with experience with amiodarone who knows what to look for in terms of pulmonary toxicity, in terms of dermatologic, in terms of neurologic, because these are side effects, toxicities that we don't test for, other than a good physical and history. So those are the things I really think that at least initially, the first year, patients should be seen at 3-month intervals until you're confident that the patient is going to tolerate the therapy at the dose prescribed. The second year, then I think you may be more comfortable going to 6-month intervals. If everything's stable. But clearly, if patients develop worsened symptoms, they get more short of breath, they have poorer exercise tolerance, that would suggest change in pulmonary status. These are folks that need to get back in and see the physician or the licensed healthcare provider who is comfortable monitoring patients on amiodarone therapy. There are some important drug interactions with amiodarone. Warfarin and DIG are two common cardiac drugs that we commonly see used in conjunction with amiodarone. Empirically, the recommendation is to reduce the dose of warfarin and digoxin by 25 to 50%. I think the challenge here is, do you reduce that dose the first day, the second day, the third day? I think with digoxin, we have evidence that the second day of combined therapy, the DIG level can be increased by as much as 70%. So I think with digoxin, initially, we're going to probably want to reduce that dose by 50%. Now with warfarin, I think you've got the INR that you can monitor, but there needs to be some empiric reduction, maybe 25% initially, because that INR, or actually the prothrombin time, is the test that's run. What that tells you is what what is going to happen 3 days down the road. The dose of warfarin and the testing that you do is delayed because of the way that warfarin works. It works by inhibiting synthesis of newly formed clotting factors. So the difficulty is, we know with drug interactions that the time that the magnitude of that interaction is the greatest typically occurs when both of the drugs are at steady state. Well, with amiodarone, that may be months. So the reality is these interactions actually occur earlier than that, and you can't discharge patients on full doses of digoxin or warfarin and expect that things are going to turn out all right. You've got to make some adjustments, typically I think in a hospital setting, and be on top of doing your prothrombin times, your DIG levels, etc. Amiodarone also interacts with cyclosporin and tacrolimus. So if you happen to have patients in your practice who are solid organ transplant or who have renal function where they're using tacrolimus for some type of renal disease, what happens is that you can see a significant increase in cyclosporin and tacrolimus levels. Amiodarone reduces their clearance. So monitor blood levels of both of those drugs. The other drugs where there's a significant interaction are your anticonvulsants, phenytoin, phenobarbital, Amiodarone increases blood levels of phenytoin and phenobarbital with resultant increases in neurologic toxicity. So again, both phenytoin and phenobarb, we have the ability to monitor those blood levels. Again, the monitoring here, I can't tell you should we be reducing doses the first day, second day, but certainly more attention needs to be paid to blood levels for all of those drugs, and dose adjustments may need to be made in the first 3 or 4 days to avoid toxicity. Well, I mentioned a new antiarrhythmic drug. We want to spend a few minutes talking about dronedarone. Again, it's been on the market for a few months, came on the market in 2009. It is a benzfuran derivative with electrophysiologic properties very similar to amiodarone, but it doesn't have the iodine component that amiodarone has. Its specific indication is to reduce cardiovascular hospitalization in patients with a recent episode of paroxysmal or persistent atrial fibrillation or atrial flutter or both. So it's really a drug that is being used to maintain sinus rhythm in a patient that's going to be cardioverted from AFib or aflutter or who has been recently cardioverted. There isn't much data looking at how effective dronedarone is in terms of converting atrial fib or flutter. There's one small study where they started amiodarone 7 to 10 days ahead of the time that cardioversion was going to be attempted. And the rate of conversion from atrial fibrillation to sinus rhythm was really quite small, about 9%. So it's not indicated as a drug for cardioversion. We think that it just hasn't been tested probably extensively enough to conclude one way or the other. But right now it's not to be used as a drug for cardioversion. It's only for maintenance of sinus rhythm. And the recommendation is also that this drug should not be used for patients with lone AFib. They really should have another risk factor that puts them at risk for adverse outcome from the AFib. So elderly, diabetes, prior history of stroke, patients with increased left atrial internal diameters, patients with low ejection fraction. Now this is interesting because that's a risk factor, and yet people with low ejection fractions who have heart failure, it's a relative contraindication to dronedarone. So be careful choosing patients with poor ejection fractions as potential candidates for dronedarone. We'll talk about that in just a minute. Slide 20, there's only one dose of dronedarone that's approved by the FDA, and that's 400 milligrams twice a day. And it is recommended that amiodarone be administered with food. So take it with breakfast, take it with the evening meal, space it out as far apart across the course of the day as possible. Taking it with food improves the bioavailability. Its bioavailability is still only 15% or so when you take it with a high-fat meal. The other recommendation is to stop Class 1 and Class 3 antiarrhythmic drugs and other potent 3A4 inhibitors, drugs like azole antifungals, certain macrolides, certain antiretrovirals, prior to starting dronedarone. The question that comes up frequently is, what do we do in the patient who's on amiodarone and is having a side effect, let's say, or it didn't work, and you want to switch from amiodarone to dronedarone? Well, there's a couple of things that have been done in studies with these two drugs. Some of the early trials, they actually started dronedarone the day after you stopped amiodarone. And there isn't any evidence necessarily that that was associated with an increased risk of toxicity. But the more recent trials, the larger trials, have actually discontinued amiodarone for 30 days prior to starting dronedarone. Now, part of that may be that the studies required that patients have a certain number of episodes of atrial fibrillation in order to qualify for the trial. So if you left the amiodarone on, then the number of episodes of AFib certainly would not have been reflective of what the natural history of that disease was. So I think, at least in our practice, if we have a patient with a problem on amiodarone and they want to switch to dronedarone, we have no problem basically stopping amiodarone. The next day you start the dronedarone. You know there's going to be some interaction, particularly in terms of QT, but the potential for torsade with these drugs relatively low. Now, one thing that you'll probably hear if you work in the cardiology field, you'll hear from the reps that sell this dronedarone that, oh, this is a drug that can be started in an outpatient setting. There's no requirement in the package labeling that patients be hospitalized. Well, and I guess I can't argue the fact that it's not there. It isn't. But I guess I feel uncomfortable starting any antiarrhythmic drug in an outpatient setting. There are too many important variables that I think we need to make sure are evaluated before starting any antiarrhythmic drug: electrolytes, ECG intervals, renal hepatic function. And I guess there are physicians that feel comfortable doing that in an outpatient setting, but I guess I don't. And so I really feel that that the best way to initiate dronedarone would still be in that patient who is in a hospital setting where you may not need 3 days like it's recommended for dofetilide, but at least 1 day, maybe 2 days to get that conversion would make me feel more comfortable. Slide 21 reviews the contraindications for dronedarone, and you'll notice we mentioned before class 4 heart failure, or patients with class 2-3 heart failure with a recent episode of decompensation, or who have been referred to a heart failure clinic. Not certain why the heart failure clinic, other than typically they get the sicker patients. But we have patients that live in rural areas that are sick that we'd like to refer to a heart failure clinic and can't because the patient's not willing to travel the distance required. So I think the point is, if you have a patient with class 2-3 heart failure and you think they are relatively sick in terms of, that they're not going to do well if you add a drug that may cause an inhibition of contractility, that may be more important than whether they got referred to a heart failure clinic or not. Second and third degree of block, sick sinus syndrome or bradycardia, unless the patient has a pacemaker. That's just common sense. A concomitant use of potent cytochrome P450/3A4 inhibitors. Azole antifungals, particularly ketoconazole, certain macrolides, cyclosporin, antiretrovirals. Those are drugs that should not be given concomitantly with dronedarone. Drugs that will increase the QT interval have to be very cautious here. It's actually a contraindication. Patients who have QT corrected intervals greater than 500 milliseconds or PR intervals greater than 280 milliseconds at baseline, patients with severe hepatic function, and then women who are pregnant or plan on becoming pregnant or nursing. Slide 22 lists some of the warnings. Patients develop new or worsened heart failure while they're taking dronedarone. The drug should probably be discontinued because we think that dronedarone may be causing the heart failure. That's the potential. Obviously, electrolytes. You've got to avoid hypomagnesemia, hypokalemia. That will increase potentially the risk of proarrhythmia. If the QT interval increases above 500 milliseconds, you have to discontinue dronedarone. About 28% of patients in the clinical trials who received dronedarone had substantial increases in QT intervals. This drug increases serum creatinine. The average increase is only 0.1 milligram per deciliter, but more than half, 51% of patients, had greater than a 10% increase in serum creatinine at about 5 days after starting therapy. Now, it's reversible when you stop the drug, and it does not indicate that the drug is causing renal damage. This is simply that it blocks tubular reabsorption of creatinine, and so it's not a sign of renal toxicity. But it does indicate that you need to readjust your baseline serum creatinine or creatinine clearance, you then have to understand you would not discontinue certain drugs because of that increased serum creatinine. Women of childbearing potential, I mentioned that earlier under contraindication. If there's a woman of childbearing potential that can use appropriate contraception, then that would be an acceptable precaution, and they could then receive dronedarone. Slide 23, I think this is the real advantage of dronedarone. If you look at side effects from trials up to a year in duration, the most common side effects are going to be GI-related. Diarrhea, nausea, abdominal pain are the most common. Weakness or asthenia, 7% compared to 5% with placebo. Some skin rash. Overall rates of drug discontinuation for suspected side effects, 12% with dronedarone, 8% with placebo. So this is a drug that, compared to amiodarone, it doesn't have the laundry list of non-cardiac side effects. So in slide 24, to date, no evidence of pulmonary, thyroid, ophthalmologic, or hepatic toxicity. I should also say, probably, to my knowledge, no evidence of neurologic toxicity. But monitoring, as with any antiarrhythmic drug, I think is key. And I've got the list of things that this should be something that we all look at before we start any antiarrhythmic drug. ECG intervals at baseline. What are the electrolytes? You'd like to have the potassium at 4.5 or even a little higher. Renal hepatic function. Some drugs cleared renally, some hepatically. Vital signs. You wouldn't start one of these drugs in a patient who was hypotensive or bradycardic. Concomitant disease states. Do they have heart failure? Clearly important for dronedarone. Renal disease for patients on sotalol or dofetilide. And then drug interactions. There are some drug interactions with dronedarone, slide 25. It is metabolized by cytochrome P453A4. It's a moderate inhibitor of cytochrome P453A4 and 2D6. It also can block or inhibit P-glycoprotein transport, which may explain the reason that it interacts with digoxin. There are some pharmacodynamic interactions, and what that means is that there's potentiation of the pharmacologic effect of either dronedarone or its interacting drug, but not necessarily changes in blood level. So the pharmacodynamic interactions are basically with beta blockers, non-dihydropyridine calcium antagonist, and digoxin. What you would expect to see there would be slower heart rate, a higher degree of AV block, potentially more heart failure, at least with beta blockers and non-dihydropyridine calcium channel blockers. And then also drugs that increase the QT intervals. We'll talk a little bit about Torsade later on in the third lecture, but if you have a concern, is the drug that we're starting on top of dronedarone a drug that increases the QT interval, there is a website called qtdrugs.org where you can go and observe lists of drugs in a database that will tell you, is this a drug that should be avoided because of its potential to increase the QT interval. Now, there are also some pharmacokinetic interactions, and on slide 25, the same slide we were just on, drugs that affect dronedarone. Ketoconazole, a 17-fold increase, contraindicated. Grapefruit juice, a 3-fold increase in dronedarone level, contraindicated. Rifampin, decreased exposure by 80%. So it actually accelerates metabolism of dronedarone and may make it ineffective. We would assume that phenobarbital, carbamazepine, phenytoin, St. John's wort, other enzyme inducers may produce the same phenomenon. So you have to be careful with those drugs. Verapamil diltiazem, increased exposure by 1.4 to 1.7 fold. So again, caution with those drugs. Now on slide 26, drugs that dronedarone affects. So these are drugs where if you add them to dronedarone will increase or decrease their blood levels. Simvastatin, highly lipophilic class 3A4 metabolized drug. Dronedarone increases simvastatin levels by a factor of 4-fold. Probably the maximal dose of simvastatin that should be used with dronedarone would be 20 milligrams a day. Anything higher could potentially lead to an increased risk of myopathy. Dronedarone increases blood levels of the non-dihydropyridine and dihydropyridine calcium blockers. So there's a dual interaction there. They both compete for cytochrome P453A4 substrate. So calcium channel blocker blood levels are increased by 40 to 50%. Should be cautious there. Increased exposure to tacrolimus and sirolimus when they're given orally. So again, that renal patient that may be taking tacrolimus for some kind of intrinsic renal disease, monitor the blood levels. Increases blood levels of metoprolol and pranolol. Again, these are typically 2D6 metabolized drugs. Dronedarone is going to compete for that. It's going to inhibit some of the 2D6 activity. So 30% increase in propranolol, 60% increase in metoprolol. There may be the potential SSRIs, drugs like fluoxetine, sertraline. They're metabolized by 2D6, and dronedarone may increase exposure to those drugs. Now, the SSRIs typically are not very toxic. You know, patients probably won't experience side effects when you combine them with dronedarone, but there may be the potential for that. Digoxin, a significant interaction, a 2.5-fold increase in DIG levels. I think pretty much the same warning that you would have for amiodarone. You're going to have to reduce empirically that dose of DIG by 25 to 50%, and probably do that early during the course of therapy. One of the advantages with dronedarone is that it does not interact with warfarin. Now, there is a little bit of evidence that it increases a blood level of one of the enantiomers of warfarin, but no clinically important change in INR. So I think that's a real advantage for dronedarone. Special populations, and this is kind of difficult, slide 27. We know that there are some patients that are going to have increased blood levels of dronedarone. Women, Asian populations, patients over the age of 65, and certainly as you get older, probably even greater effect in terms of AUC. None of the drug is cleared unchanged renally, so renal function is not an issue. But moderate hepatic disease will increase blood levels by 30%. The problem that we have is there's no alternate dose available for dronedarone. It's a fixed dose of 400 milligrams twice a day. Nothing in the package insert tells us that we can back off to 400 once a day or 200 BID. So we know that there's the potential for greater toxicity in these populations. I simply think what this means is we really need to be more careful in monitoring those patients where there's going to be the potential for increased blood levels of dronedarone. Slide 28, efficacy of dronedarone. There are a number of trials. The pivotal study that got this drug approved was called Athena. Double-blind, randomized, placebo-controlled study, 4,600 patients, history of AFib flutter. What they were looking at was cardiovascular hospitalization or all-cause mortality as the primary outcome. It occurred in 39% of patients on placebo, 32% with dronedarone. So about a 24% relative risk reduction, highly significant. So from that perspective, it was approved. The study that really, I think, causes the most concern was Andromeda. But the difficulty with Andromeda is that it was a heart failure trial. Patients had to be hospitalized with heart failure and severe left ventricular dysfunction, but did not have to have atrial fibrillation. So they randomized patients to placebo or dronedarone, double-blind, and the endpoint was all-cause mortality or hospitalization for heart failure. I'm not certain why, but the manufacturer thought, we'll get a heart failure indication for this drug when it's an antiarrhythmic agent. Well, they stopped the study prematurely after 627 patients had been enrolled out of the 1,000 that were supposed to have been enrolled. And that was because mortality was increased, 8% with dronedarone, about 4% for placebo. So a twofold increase in mortality. The primary cause of death was worsening heart failure. One of the issues with the study is that I don't think they completely understood that dronedarone increased serum creatinine, that it was not related to renal damage. And what happened was that there was an increase in the number of patients in the dronedarone group that had ACE inhibitors discontinued. These were severe heart failure patients. Stopping ACE inhibitors may have caused the increase in mortality. We don't know. Subgroup analysis was not robust enough to tell us that that was the reason for the increase in mortality with dronedarone. So the warning, the contraindication stands as we've already discussed. Slide 29, the Dionysus trial has not been fully published. The abstract is available. There's been a meta-analysis where the results of this trial were included. I don't know what's holding up the full publication, but as of February of 2010, we don't have the complete publication. It is the only head-to-head comparative trial of amiodarone and dronedarone. 504 patients followed for 7 months. So and all of these had persistent AFib. So not a huge number of patients, not probably truly powered for mortality, and not a long follow-up. The composite endpoint was recurrence of AFib or premature drug discontinuance due to intolerance or lack of efficacy. Amiodarone actually had a better outcome in terms of fewer episodes of AFib, lower risk of the primary endpoint, which was statistically significant. There were about 74% of the patients who reached the primary endpoint with dronedarone, 55% with amiodarone. As I said, the number of patients requiring electrical cardioversion occurred in about 36% of the dronedarone patients compared to 24% with amiodarone. So amiodarone clearly was more effective in terms of preventing AFib recurrence. But what favored dronedarone in the trial was that there was a relative reduction of about 20% in rates of discontinuation for the primary safety endpoints, which were thyroid, pulmonary, hepatic, ocular, neurologic, and skin disorders. So there were 83 patients that developed one of those problems with dronedarone compared to 107 with amiodarone. And it didn't reach the statistical significance. The p-value was 0.12. But I think it tells us that, yeah, dronadarone's safer, but the duration of follow-up was short, numbers of patients were small. But it also tells us that amiodarone is probably a more effective drug for preventing recurrences of AFib. In Dionysus, and this is slide 30, in Dionysus, GI events were more common with dronedarone compared to amiodarone, but dronedarone caused less drug discontinuation, less QT interval increases, and less bradycardia than amiodarone. And again, this was not adequately powered to look at mortality, so we don't really know what that may end up being. You know, is the rate of the non-cardiac toxicity with amiodarone great enough that it would end up increasing mortality, you know, with a longer-term study? So slide 31, what are the clinical implications of the availability of dronedarone? Well, I truly think it is a safer alternative, but at the same time, it's also less effective. So only time will tell, I think, how this plays out. in terms of, what is the real value of dronedarone. Would it be only for patients who fail amiodarone because of toxicity? And I can't tell you that. I think at the present time, if you have a patient who's tolerating low-dose amiodarone, not having side effects, being well controlled, no reason to switch to dronedarone. For patients that have had a side effect on amiodarone, certainly dronedarone makes some sense. And I think the easy thing is, I think they probably need to be hospitalized, switch that patient to dronedarone the next day. You do have the alternative of stopping amiodarone for 30 days and then starting the dronedarone. And I guess you could do that in an outpatient setting, but that probably would not be the practice that I would recommend. Certainly, if you have a patient that has new onset AFib, persistent paroxysmal, you've got a choice. You could consider dronedarone rather than amiodarone. And I think part of it may be if you have a very young patient in their 50s with persistent AFib, do you want to expose them to amiodarone for many, many, many years with the non-cardiac toxicities that we know go along with amiodarone? So that may be an option. I do think one of the major limiting variables with dronedarone is the fact that many patients with AFib have poor LV function. They have a history of heart failure. They have poor ejection fractions. So I think the fact that you have this contraindication or warning in using dronedarone in patients with heart failure may limit the number of patients that would potentially benefit from that therapy. So ultimately, I know this may sound like a cop-out, but it's true. Ultimately, the role of dronedarone, I think, right now is undefined. I think patients with amiodarone-induced toxicity make sense. Patients who are young or you don't want to expose them to years of amiodarone, it makes sense. But other than that, I'm not certain that there are really a number of good clinical scenarios where dronedarone would be superior to amiodarone. One other issue is cost. Now, even though amiodarone has been generic for a number of years, we've looked locally at our pharmacies what they're charging for amiodarone, and it's $4 a day. Dronedarone is even worse at $7 a day, and this is based on the U.S. market if patients had to pay out of pocket. So I think it's very important that these drugs be put on prescription coverage plans so that patients have the ability to afford them, because $7 a day for an oral medication you may need to take for 3 to 5 years or so or longer, that's a significant amount of money to be paying for oral medication. So that concludes the first of 3 presentations for cardiac arrhythmias. We've just finished talking about some of the therapeutic properties of the antiarrhythmic drugs, and the next in the series we'll be talking about managing supraventricular arrhythmias. Thank you.